Good morning, everyone. Today I am going to discuss a very common but an important topic, vomiting and diarrhea. So first we will see the vomiting, the physiology of that, the mechanisms and everything. Then the next video we will be seeing or looking in the diarrhea. If you take the vomiting and diarrhea, these are the symptoms we see every day in your clinical practice. Although the vomiting and diarrhea are often due to simple self-limiting gastroenteritis, they can sometimes cause serious illness. First, we will discuss the biochemical derangement that occur in diarrhea and vomiting. It is very important because patients do not become seriously ill only because of they are passing some stools and they just vomit. They become ill because they lose water, electrolyte, there's an acid-base imbalance. Okay. For example, in diarrhea, obviously we lose water, sodium, potassium, and bicarbonate. In vomiting, we're losing hydrogen ion and chloride. This can lead to dehydration, electrolyte imbalance, and metabolic acidosis or alkalosis. Even it can cause shock in severe cases. Then we'll be looking at the mechanism of vomiting. Vomiting is not a simple event. It is a well-coordinated reflex controlled by the brainstem. So we'll be look at the vomiting center, its location, its connection, and how it receives signals from different part of the body. We'll be discussing that. And we'll mainly discuss chemoreceptor trigger zones and what are the toxin causes nausea and vomiting, and how the oral rehydration solution has a place on that. So these are the few pictures to tell you what is vomiting. Let us start with vomiting. Vomiting is defined as a forceful expulsion of the stomach content via the mouth. Sometimes the content from the upper part of the small intestine, especially the duodenum, can also be expelled. That is why vomiters may contain bile, particularly duodenal content are involved. It is important to understand that the vomiting is not a passive process. It is an active, coordinated reflex. Several muscles take part in it, including the abdominal muscles, diaphragm, stomach, esophagus, and upper airway muscles. Because it is forceful, the patient may feel abdominal contraction, retching, sweating, salivation, and discomfort before the actual vomiting occurs. Vomiting is caused mainly through two pathways. One is humoral stimulation of the chemoreceptor trigger zone. Other pathway is neural stimulation of the emetic center. That is called vomiting center. So one is humoral, other one is neural. The most important point here is the vomiting is a reflex response integrated in the medulla oblongata. The medulla acts like the coordinating center. It receives input from different sources, processes the information, and then sends motor signals to produce the act of vomiting. Vomiting is usually occurs in three phases: nausea, retching, and vomiting. The first phase is nausea, that is an unpleasant feeling that the person may vomit. It's a warning sensation and usually occurs before actual vomiting. During nausea, the patient may say, I feel like vomiting. Nausea is commonly associated with autonomic symptoms like salivation, sweating, palpitation, and sometimes dizziness. The second phase is retching. Retching is a strong involuntary attempt to vomit, but without actual expulsion of stomach content. So this may sometimes called as dry vomiting. The patient may make repeated vomiting movement with contraction of the diaphragm and the abdominal muscles, but nothing comes out. Third phase is actual vomiting. It is the actual expulsion of the gastric content through the mouth. This happens when strong contraction of the abdominal muscles and diaphragm increase intra-abdominal pressure. At the same time, the lower esophageal sphincter relaxes. The stomach content move upward and the upper esophageal sphincter open. This allows gastric content to be expelled through the mouth. So this is how people vomit. After vomit, they tire. Now, we are going to look at the sequence of events. You should be able to tell it's like a story. So when we ask in the SEQ, you may be able to tell them. So now let us look at the sequence of events that occur during vomiting. Vomiting usually starts with salivation and sensation of nausea. Salivation is actually a protective response. Since gastric content are acidic, increased saliva helps to dilute and neutralize the acid and protects the mouth, teeth, and esophagus from injury. Then there is a reverse peristalsis. Normally, intestinal movement pushes content downward. But before vomiting, the direction can reverse. Material from the upper part of the small intestine may move back into the stomach. This is why vomiters may sometimes contain bile, especially when the vomiting is repeated or forceful. Then, an important protective event occurs. The glottis closes. This prevents vomiters from entering the trachea and lung. If this protective mechanism fails, the patient may aspirate gastric content with an which can lead to aspiration pneumonia. This is especially dangerous in unconscious patient, intoxic patient who was undergoing or right now who is having a seizure episode, stroke, or patient with reduced airway reflexes. At the same time, breathing is held in mid-inspiration. This helps to stabilize the thorax and coordinate the vomiting reflex. It is also supports close of the airway during the act of vomiting. After that, the abdominal wall muscles contract strongly. The diaphragm also contributes. These contractions increase intra-abdominal pressure. This pressure is the main force that pushes gastric content upward. Then the lower esophageal sphincter and the esophagus relax. Normally, the lower esophageal sphincter prevents gastric content from moving back into the esophagus. But during vomiting, it relaxes, allowing the content to move upward. Finally, gastric contents are ejected through the mouth. So the vomiting is highly coordinated reflex. It includes gastrointestinal movement, respiratory protection, abdominal muscle contraction, sphincter relaxation, and expulsion of gastric content. Clinically, this sequence explains why vomiting can be dangerous in certain situations. The main immediate risks are dehydration, electrolyte imbalance, aspiration, and injury to the esophagus if vomiting is severe or repeated. The control of vomiting is just a sarcastic picture, okay? This slide is very important and it summarizes the controls of vomiting system. It may look a little complex, but the main idea is simple. Vomiting is controlled by the brainstem and many different parts of the body can signal to trigger it. At the center of this pathway is the dorsal vagal complex in the medulla. This includes important areas such as nucleus tractus solitarius, dorsal motor nucleus of the vagus, and the area posterior. These brainstem areas receive information from different sources and coordinate the vomiting reflex. One important input comes from the gastrointestinal tract. That is very important input. Irritation, infection, distension, toxin, inflammation, obstruction, or chemotherapy-related stimulation can activate enterochromatin cells and the enteric nerves in the gut. These signals travel mainly through the vagus nerve and also through splanchnic nerves to the brainstem. This is why gastroenteritis, food poisoning, gastritis, and intestinal obstruction commonly cause vomiting. Another important area is the chemoreceptor trigger zone, which is located in the area postrema. This area is special because it can detect chemicals in the blood and cerebrospinal fluid. It is sensitive to drugs, toxin, metabolic disturbances, pregnancy-related hormones, infection, and chemotherapy agents. Once stimulated, it activates the vomiting center in the medulla. The vestibular system also sends input to the vomiting center. This explains vomiting due to motion sickness, labyrinthitis, and other inner ear problems. In these cases, the patient may have nausea, dizziness, vertigo, and vomiting. The vestibular pathway is also connected with the visual cortex and cerebellum, which is why visual movement can worsen motion sickness. Higher brain centers can also trigger vomiting. Emotional stress, fear, pain, unpleasant smell, bad taste, or seeing something disgusting can stimulate higher cortical and limbic areas. These centers then send signals down the vomiting center. This is why vomiting can occur even without a primary GI disease. Visceral efferent from other organs can also contribute. For example, MI, gallbladder disease, kidney disease, peritonitis, and severe pain can cause nausea and vomiting through visceral sensory pathways. Once the vomiting center is activated, it sends motor outputs through different nerves. These outputs coordinate the diaphragm, abdominal muscle, stomach, esophagus, pharynx, larynx, and abdomen. This produces the sequence we discussed earlier. This slide shows how different signals reach vomiting center. The main coordinating area is the vomiting center. It gets signals from chemical trigger zone, CTZ, circulating toxins, and higher centers stimulate chemical trigger zone or chemoreceptor trigger zone. Then that stimulate vomiting center. So here if you say labyrinth receptors stimulate vestibular nuclei, then it stimulates vomiting center, then the vomiting occurs via the efferent. Even the vagal efferent from the stomach, sympathetic efferent, spinal nerve also, they give input to vomiting center. Circulating toxins and emetic substances in the blood stimulate chemoreceptor trigger zone. Once chemoreceptor trigger zone activated, it activates vomiting center. Then vomiting center in turn activate or send motor command via the efferent nerves to the muscles of vomiting. So here we will see afferent impulse for vomiting, irritation of the mucosa, vestibular apparatus, even the myocardial infarction, heart, limbic cortex and other system can cause that. So we'll look that in bit depth. Afferent impulse means the incoming signal that travel from different parts of the body to the vomiting center in the medulla. The first and most common source is the gastrointestinal tract. Irritation of the mucosa in the stomach, duodenum, or other part of the GIT can stimulate vomiting. The irritation may be due to infection, toxin, gastritis, food poisoning, gastric distension, intestinal obstruction, or inflammation. These signals mainly travel through the vagus nerve and sympathetic afferents to the vomiting center. The second source is the vestibular apparatus, especially in the inner ear. This is important in motion sickness when there is a mismatch between the visual input and the vestibular input. The vestibular nuclei stimulate the vomiting center. This is why People may develop nausea and vomiting while traveling by bus, car, boat, or airplane. Vestibular causes are often associated with dizziness, vertigo, and imbalance. The third source is the heart, especially during MI. Sometimes patients with inferior wall MI may present with nausea, vomiting, sweating, and epigastric discomfort, no classical chest pain. Therefore, vomiting should not always be assumed to be gastrointestinal in origin, especially in older patients or patients with cardiovascular risk factors. So these are common things. You will see patient just coming you with vomiting. You treated for the symptoms, you treat the vomiting, but that is due to the inferior MI, especially in patient with diabetes. They don't complain chest pain, vomiting, you treat for gastritis, the patient died. So remember that. Another important pathway is through the limbic cortex and higher brain centers. Emotions can trigger vomiting, for example, fear, anxiety, unpleasant memories, noxious smells, bad taste, or sickening sights can stimulate these higher centers and then activate the vomiting center. Especially, we will be look at the non-gastrointestinal causes. The vomiting can occur in urine and renal failure. Waste products such as urea and other toxins accumulate in the blood. These circulating substance can stimulate the chemoreceptor trigger zone and produce nausea and vomiting. So in a patient with persistent vomiting, especially with the reduced urine output, edema, hypertension, or a known kidney disease, we should think about renal causes also. Similarly, vomiting in radiation sickness or during radiotherapy is also mediated through chemoreceptor trigger zone. Radiation and tissue injury can release chemical mediators and toxins that stimulate this area. That is why nausea and vomiting are common side effects in patients receiving radiotherapy or chemotherapy. The next important point is raised intracranial pressure. Increased intracranial pressure inside the skull can stimulate the vomiting center directly. This can cause projectile vomiting, which means sudden, forceful vomiting. Classically, it may occur with little or no preceding nausea. This is very important clinically because projectile vomiting, especially when associated with severe headache, visual disturbances, altered consciousness, seizures, papilledema, or neurological sign is a red flag. We should not treat it as a simple gastritis or gastroenteritis. The third point is severe visceral pain. You have seen that. Especially renal colic, biliary colic, MI, testicular torsion, even pancreatitis can cause nausea and vomiting. Now we look at the vomiting center. That is stimulated in the medulla oblongata, which is part of the brainstem. This is an important area because it controls many vital reflexes, including respiration, cardiovascular reflexes, swallowing, coughing, and vomiting. The vomiting center receives input in two main ways. The first and direct input is signals can come directly from the gastrointestinal tract, especially from the stomach and duodenal mucosa. Second is the indirect input via chemoreceptor trigger zone. The chemoreceptor trigger zone detects chemical in the blood and cerebrospinal fluid. When drugs, toxin, metabolic waste products, or other emetic substance stimulate chemoreceptor trigger zone, it then activates the vomiting center. Examples include uremia, especially certain drugs, chemotherapy, and radiation signal. Once the vomiting center receives these signals, it controls and integrates both visceral and somatic function involving in vomiting. The visceral function include motility, relaxation of the lower esophageal sphincter, increased salivation, and autonomic symptoms like sweating or pallor. The somatic function include contraction of the abdominal wall and diaphragm, close of the glottis, and coordination of the respiratory muscle. These somatic movements generate the pressure needed to expel gastric content safely through the mouth. So the vomiting center acts like a coordinator. It receives information from different sources, decide where the vomiting should occur, and then send a coordinated output to the gastrointestinal tract, respiratory system, abdominal muscle, and upper airway. The key and important point to remember is vomiting is not controlled by the stomach alone. It's a medullary reflex integrated by the vomiting center with inputs coming either directly from the body organs or indirectly through the chemoreceptor trigger zone. Now let us discuss chemoreceptor triggers. It's commonly called CTZ. It's an important area involved in vomiting. It's located in the brainstem in the area called area posterior, which lies on the floor of the fourth ventricle. It is present on both sides, so we describe it as a bilateral set of centers. The special features of the CTZ is that it acts like a chemical sensor for vomiting. It detects chemical abnormalities in the blood and cerebrospinal fluid. Unlike many other parts of the brain, the area posterior is relatively exposed to circulating chemicals. Therefore, it can easily detect toxins, drugs, and metabolic changes. For example, emetic drugs can stimulate chemoreceptor trigger zone. Metabolic problems such as uremia, hypoxia, diabetic ketoacidosis can also stimulate this area. Once the chemoreceptor trigger zone is stimulated, it does not directly produce the final act of vomiting by itself. Instead, it sends excitatory signals to the vomiting center in the medulla. The vomiting center then coordinates the full vomiting response through the gastrointestinal tract, respiratory muscles, and abdominal muscles and cranial nerve. This is clinically very important because many antiemetic drugs act at the level of chemoreceptor trigger zone. For example, some antiemetic block dopamine receptors, serotonin receptors, or other receptors involved in vomiting center. By blocking these receptors, they reduce stimulation of the vomiting center and help to control nausea and vomiting. So, the chemoreceptor trigger zone is the chemical surveillance area for vomiting. The diagram shows cross-section of the medulla and help us to understand how is the relationship between chemoreceptor trigger zone and the vomiting center. Now we look at the important receptor involved in vomiting. Vomiting is controlled by several pathways, and each pathway uses different neurotransmitters and different receptors. This is clinically important because many antiemetic drugs work by blocking these receptors. First, we have muscarinic acetylcholine receptors, also called ACHM receptor. These receptors are present in the vomiting center and also in the vestibular nuclei. They are especially important in vomiting related to the vestibular system, such as motion sickness. When someone travels by bus, boat, or car, signals from the inner ear can stimulate vestibular nuclei and then activate the vomiting center. Drugs with anti-muscarinic action can reduce this type of vomiting. Second is the dopamine receptors or D2 receptors. These receptors are mainly present in chemoreceptor trigger zone. Many blood-borne chemicals, drugs, and metabolic abnormalities stimulate the chemoreceptor trigger zone through dopamine pathway. Therefore, drugs that block D2 receptors can be useful in nausea and vomiting caused by drugs, toxins, uremia, and some gastrointestinal causes. Third, we have the 5-HT3 receptors or serotonin receptors. They are found in both chemoreceptor trigger zone and gastrointestinal tract. In the gut, the irritation or injury can cause release of serotonin from enterochromaffin cells. This serotonin stimulates vagal afferent nerves and sends signals to the vomiting center. The serotonin receptors are very important in vomiting caused by chemotherapy, radiotherapy, gastroenteritis, and post-operative status. That is why 5-HT3 antagonists such as ondansetron are very effective antiemetic in post-op patients. Fourth, we have the H1 receptors, which are histamine receptors. These are mainly present in the vestibular nuclei. They are important in vomiting due to motion sickness and vestibular disorder. Antihistamine can reduce nausea and vomiting in these conditions. So the key receptors to remember are muscarinic receptors in the vomiting center and vestibular nuclei, D2 receptors found in the chemoreceptor trigger zone, serotonin receptors in the chemoreceptor trigger zone in GI tract, histamine receptors in the vestibular nuclei. The practical importance is that different causes of vomiting may respond better to different antiemetic drugs. For example, the vomiting due to motion sickness respond well to drugs acting on vestibular pathway, such as H1 receptors antagonists. So understanding these receptors help us understanding both the physiology of vomiting and rational use of antiemetic drugs. Now we'll connect the receptor physiology with treatment in vomiting. So you can see the domperidone receptor. Domperidone is a D2 receptor antagonist. Ondansetron is the serotonin receptor antagonist. The D2 receptors and 5-HT receptors, muscarinic receptors, and histamine receptors, they are participating in different pathways. One example is domperidone. It's mainly acting as a D2 receptor antagonist. D2 receptors are found in the chemoreceptor trigger zone. So when the chemoreceptor trigger zone is stimulated by drugs, toxin, or metabolic abnormalities, it activates the vomiting center. By blocking the D2 receptors, domperidone reduces chemoreceptor trigger zone stimulation and helps control vomiting. Domperidone is also a prokinetic effect. It also has a prokinetic effect on the upper gastrointestinal tract. This means it can help improve gastric emptying and reduce nausea-related delayed gastric emptying. So we have seen the efferent pathways and we'll be looking at the efferent pathways. These are very simple. So the efferent pathways are mainly, they get the signal from the vomiting center. Once the vomiting center is activated, it sends coordinated signal to several organ and muscle. These outputs necessarily come and activate the muscles and causes vomiting in a coordinated fashion. So now we'll see what happens when there's a prolonged or excessive vomiting. When there's an excessive or prolonged vomiting, first problem occurs is a dehydration. With repeated vomiting, the patient loses water. Also, because the patient feels nauseated, they may not be able to drink enough fluids. So the loss is continuing, but the intake is reduced. This can lead to dehydration. Clinically, we may see thirst, the patient feels thirst, the dry mouth, the mouth becomes dry. You can see the dryness in the mouth, the patient complaining of reduced urine output, the sunken eyes, dizziness, and there's a reflex tachycardia because of the low blood pressure. And in severe cases, it can cause shock. You know what is shock and the complication. The second problem is electrolyte imbalance. Gastric juice contain important electrolytes such as chloride, hydrogen ion, sodium, and some potassium. When vomiting continues, these electrolytes are lost. Electrolyte imbalance can cause weakness, lethargy, muscle cramp, cardiac rhythm problem, and worsening clinical condition. The third is metabolic alkalosis. Is one of the classical acid-based changes in prolonged vomiting. The stomach contains hydrochloric acid. When the patient vomits repeatedly, there's a loss of hydrogen and chloride ion from the body. Loss of hydrogen ion means loss of acid. As a result, the blood becomes more alkaline, leading to metabolic alkalosis. Also, loss of chloride contributes to maintenance of alkalosis because the kidney needs chloride to excrete bicarbonate effectively. When chloride is depleted, bicarbonate is retained and alkalosis persists. Fourth is hypokalaemia, that is low potassium level. Potassium depletion occurs due to several mechanisms. Some potassium is lost directly in vomiters. But more importantly, dehydration activates renin-angiotensin aldosterone system. Aldosterone increases sodium reabsorption, the kidney, but potassium is secreted into the urine. The patient loses potassium through the kidney. In metabolic alkalosis, potassium also shifts into cells, further reducing serum potassium. Hypokalaemia is clinically important because it can cause muscle weakness, paralytic ileus, and dangerous cardiac arrhythmia. It can also worsen alkalosis. So the key message is prolonged vomiting can cause dehydration, electrolyte imbalance, metabolic alkalosis, and hypokalemia. When assessing a patient with repeated vomiting, we must not only ask how many times you vomit, we should also assess hydration status, urine output, pulse, blood pressure, mental status, whether he is conscious or altered conscious, and consider electrolytes if vomiting is severe or prolonged. So that is the clinical implication you will be seeing in patient when you are practicing in the hospital. So now let us see about the motion sickness. You know that it due to the vestibular apparatus. It activates vestibular nuclei, then the cerebellum, then vomiting center, and vomiting. So motion sickness is through the vestibular pathway. The promethazine is one of the H1 receptors blocker. So it is an antagonist to the H1 receptor. So it will block the H1 receptor and prevent the vomiting. And you can have some anticholinergic effect of H1 receptor antagonist also. So we will finish that with this. We have covered the basic physiology of vomiting, how it is happening, what are the factors, so what are the centers. So when something is stimulated, it either goes directly to the vomiting center or goes to the chemoreceptor trigger zone. From there, it goes to the vomiting center. Vomiting center with the coordinated function, send the motors coordinates or command to the muscle. They vomit. What are the causes and what are the receptors involved in each places? What are the receptor antagonists which can prevent the vomiting? So we have seen that. Especially when it comes to the motion sickness, you have to take H1 receptor blockers at least before 20 to 40 minutes before your journey. Once the vomiting is started, the drug is less effective. So if you are a known person with the motion sickness, before start your traveling, before 20 to 40 minutes, take the tablet, that will work. So we'll have a short break, then we'll come for the next lecture, that is diary. Have a nice day.